Okay, in these next couple of slides, we will be discussing distributive shock. So distributive shock in the physical examination, the cardinal features include changes in mental status. Just like in the other shocks, there will be anxiety, confusion, agitation, and possible loss of consciousness. Their heart rate is greater than 90 beats per minute. Hypotension, systolic blood pressure less than 90 mmHg or a reduction of 40 mmHg from baseline. Extremities are frequently warm with bounding pulses and increased pulse pressure in early shock, but as the shock progresses, may be present as a critical organ failure. Hyperthermia, the core body temperature can be greater than 101 Fahrenheit or 38.8 Celsius, or hypothermia, where the core body temperature is less than 96.8 Fahrenheit or 36 Celsius. Pulse oximetry is relative to hypoxemia and decreased urine output. Causes for distributive shock may be diseases such as pneumonia, a urinary tract infection, intra-abdominal infection, gangrene, soft tissue infection, anaphylaxis, respiratory distress, wheezing, angioedema, streptococcal TTSS, high fever, which that one will show up as a diffuse rash with desquamation on the palms and soles for 1 to 2 weeks, hypotension, and evidence of involvement of 3 other organ systems. Images and studies that are done to diagnose a distributive shock are CBCs with differentials, urinalysis, electrolytes, blood urea, nitrogen, also known as BUN, creatine, glucose, urine cultures, blood cultures, ABGs, or at least a VBG, serum lactate, especially with metabolic acidosis, or elevated anion gap is present. If pneumonia is suspected, a sputum gram stain and culture should be performed. If intra-abdominal pathological condition, hepatic insufficiency should undergo serum bilirubin alkaline phosphate, AST and ALT prothrombin time, activated partial prothrombin time, amylase or lipase. If suspected disseminated intravascular coagulation, DIC, obtain a PT, APTT, fibrin split, products, D-dimer, fibrinogen levels, platelet count, and electrocardiography. Okay, so for the next one, so for pharmacology intervention, antimicrobial coverage should be broad. With good penetration to all suspected sites of infection. An antimicrobial regimen should be tailored once the causative pathogen is identified. Corticosteroids are adjunct treatment for septic shock. Hydrocortisone is the drug of choice for this. Systemic vasopressors are indicated in patients with hypotension due to sustained septic shock in whom fluid resuscitation does not reverse hypotension. So that's the only time that they would like to use a vasopressor is when the patient has not responded to fluid resuscitation. Then they will use a vasopressor to help with that contractility of the heart to move that fluid and blood around. An ABG will present as a metabolic acidosis with an elevated anion gap and high serum lactate. pH usually is low when compensated by a respiratory alkalosis. Signs and symptoms include cardiovascular, low blood pressure, tachycardia, skin changes. Initially, skin is red, dry due to vasodilation, then becomes cool, clammy, mottled skin, neurological confusion, disorientation, lethargy, anxiety, decreased urine output and temperature, fever, or hypothermia. Monitoring. Patients should be admitted to the ICU. Vital signs, continuous vital signs, fluid intake, and output should be measured. Daily weight, adequate intravascular access secured. Oxygen should be administered by mask. Mental status, respiratory distress, or severe hypotension. Elective ET endotracheal tube placement and mechanical ventilation if needed. For patients with distributive shock, mechanical ventilation provides critical support by reducing the oxygen and demands of respiratory muscles associated with ARDS. So these patients will have a reduced consumption by respiratory muscles, so low tidal volumes to minimize lung injury, PEEP to improve oxygenation for just as the ARDS protocol. So for moderate to severe ARDS, plateau pressures need to be targeted at less than 30 centimeters of water, and positioning is recommended for these patients for more than 12 hours a day. So, as far as positioning, they will follow the ARDS protocol and they will prone patients to allow their lungs to expand and be able to help them breathe a little bit more and more effectively. These are a couple images of distributive shock. In the picture on the left, an 8-year-old boy developed septic shock secondary to blastomycosis pneumonia. Fungal infections are a rare cause of septic distributive shock, but they are possible. In the picture on the right, a 28-year-old woman who was a previous intravenous drug user and developed HIV, later developed septic shock secondary to a bilateral pneumococcal pneumonia, which is a form of distributive shock. Distributive shock is just kind of like the next step from an infection that affects the heart's ability to move that blood and circulate in the circulatory system.